you know, I've got to get the YouTube, Facebook, which is now on, and the most recent addition, which is the TikTok. Yeah, he's on well, I've been on TikTok for a while actually, but I thought I needed 1,000 followers to be able to do live, but I've only got 600 or something. So, and or I don't know what I've got, but I haven't got 1,000, and I am allowed to go live. So there you go, live. I'm live. There you go, on TikTok. And so, oh, something went wrong. Try again later. Okay, maybe I'm not live on TikTok. Am I live? What does that say down there? Keep going. We're letting your viewers know. Okay, I'm going to keep going. Keep up the momentum. I'm sure the viewers will be here shortly, but until then, we'll get started. I have no doubt that there will be a deluge of fans any minute now. But let's just do the questions while we're waiting, shall we? So here's some questions that people have asked me. I'm going to kick off with this one, which goes a little bit like this. Do we offer ear enlargement at our clinic? Exploring options for ear enlargement stroke reshaping, as my ears are smaller than I feel would be proportionate to my face. I'd like to inquire about the specific techniques you offer for resizing small ears and whether you can customize the procedure to enhance both the size and shape of my ears. It's unusual to have a small ear issue, or at least as an adult, it's unusual to have a small ear issue. Small ears are a thing that can happen congenitally. Babies can be born with small ears, and it is called microtia, which is small ear, microtia, and it is a specific branch of plastic surgery involved in reconstructing those ears, which is often quite extensive, often quite staged. So several procedures are needed, and it's as I say, there's only a handful of plastic surgeons who will actually perform ear reconstruction for congenitally small ears. So I'm feeling this is not a microtia. Oh, I feel it close on TikTok. I feel that this is not a microtia question. I feel this is someone who feels that their ears, well, they've said their ears are small. So reshaping ears, we certainly do. And the flip side is normally true, actually. People think that their ears are big and want them reduced. And we don't actually reduce or enlarge ears. What we do is we reshape ears, which means that we make reshape the cartilage. So bring the cartilage back and recreate. Often either there's two common problems you get with people who have prominent ears. One is the loss of the antihelical fold, which is this fold here. This is the helical fold, the outer one, and the antihelical fold is the inner one in the aspect of the ear. So one is the loss of that. So if that's lost and the ear is out like this, then we can recreate it by folding it back. And the other is the deep scapha. This is a scaphoid bowl. This bit in here, this is called the scapha, so a reduction of the scapha. So you can take a wedge and reduce the scaphoid bowl, and or recreate the antihelical fold. So it might be one or other, or a combination of the two. And that's basically to reshape an ear. So as I say, commonly people think they're big, but they're often not big. Often it's just that the shape isn't right, and if they're prominent, so we reshape them back. So if you were going to make an ear a different size, it would potentially be easier to make it smaller rather than larger, and that would we do sometimes do wedge excisions of the ear to take a wedge out of the ear. but that's for a skin cancer. So if you have a skin cancer on the ear, you can take a wedge, so like a slice of cake out of the ear and then close it down, and actually it looks really good, because you often can do it on one side and not the other, and it looks really good, and you often can't particularly tell. So it's possible to actually make an ear smaller, but the only time it is kind of commonly done is if you've got a skin cancer, to take a wedge out, and certainly making an ear bigger is not. So the question is how what are our specific techniques we offer to resize small ears? We haven't got any techniques to resize small ears, so we do not offer ear enlargement. If you do feel that is the issue, that the ear is too small, then an ear specialist would be the way to go. David Galt is traditionally the one that people turn to, somewhere East Grinstead or somewhere, I think, not quite, or Mount Vernon. I'm not sure where he is, but he's somewhere kind of the London area. I'm not sure if he might be sort of retirement, I'm not sure. In Birmingham there's Mark Lloyd, but again I don't know, he might have retired as well, but he's doing a lot of property stuff. So Mark Lloyd is and there's a few dotted about the country, ear plastic surgeons. So we've all got subspecialty interests, but there are more common subspecialty interests like burns and hands, and craniofacial and breast. Those are the sort of common ones. Ear is not a common one, but there are a few ear specialists in the country, and they would deal with microtia, small ears. But as I say, it's usually a congenitally small ear that we're talking about, rather than just making a kind of normal, if you like, a normal ear, enlarging that. That's actually not something that we offer, and not something I'm familiar with anyone offering really. But you would best place to talk to a ear reconstructive surgeon. Yeah, good one, nice one. That crowd's rolling in now. Can you remove a birthmark / mole without any scarring? Well, a birthmark maybe. So a birthmark, it kind of depends on what color the birthmark is. So if it's like a red birthmark, so if it's a vascular birthmark, sometimes you get brown ones, kind of like moles, which are also birthmarks. But a red one, it might be possible to treat with laser, and there are lasers which will specifically target the red pigment, and that would not necessarily leave any scarring. Sometimes you can get scarring with laser, but the good thing about laser is that it is good for red birthmarks. And interestingly, I've got a question about this later on. But anyway, but a brown birthmark, so a mole, a mole, like a pigmented brown mole, or a pigmented brown birthmark, then the laser that will be required for that will be a CO2 laser, which is an ablative laser. I don't do laser, so I'm not an expert in laser. So if you do want to talk about laser, you probably need to talk about someone who sort of does it. But a CO2 laser kind of like cuts a bit like a knife, and would be leaving similar scarring to a cutting it. And the thing about cutting it and scars and things like that is that we do sometimes get into situations where we have cut something out and given a scar, but it heals really well, so that it doesn't look like they've got a scar, and they think they haven't got a scar, which is obviously a great position to be in. But it you have got a scar, but it's just so good that you can't see it. So strictly speaking, a kind of brown birthmark or a brown mole will need to be removed by removing that piece of skin. And I guess it comes down to how superficial the mole is. If the mole's quite thin and superficial, you might be able to get away with just taking the top layer of the skin off, not having a full thickness skin injury, and therefore that wouldn't leave any significant scarring. But that would be quite a superficial thing. Things like seborrheic keratoses, sometimes you can just sort of kind of shave off or scrape off, and you don't have a full thickness injury to the skin. And once they heal, they can heal without any obvious scarring. The problem with the kind of less skin that you take off, it only works for things that are quite superficial. Often it has to be raised. You can't do it with a flat one, and because you're only taking the superficial layer off, if there's any pigment, if there's any brownness deeper, and with a lot of moles the pigment goes deeper than the sort of level of the shave, then you can end up with a flat brown thing, which can look similar to the raised brown thing, unless it's the raised nature that's the main issue. But if it's the fact that it's a mole, the mole might kind of still be there. If it's a brown one, skin colored ones or lightly pigmented ones which are raised, and seborrheic keratosis has this classic stuck on appearance. Those sorts of lesions have the possibility of a shave excision where you can remove it without scar. What's it? Someone said hello. Oh, glasses on. Okay, Maddie is a cat has said hello. How are you doing, Maddie is a cat? I'm okay. How often do you say, oh, here we go, sassy amore, number one. How often would you, oh, we've got the headmaster's hair team. Oh, hi, Katie. Oh, Liz. Hi, Liz. It's amazing what happens when you put your glasses on. How, please ignore my, oh, just Maddie. Okay. Sorry, how often you say breast implants need changing? I've done the birthmark more, yeah. So, well, a lot of people say they've got to be changed every 10 years. I don't subscribe to that. And sometimes people come and say, oh, my breast implants have been changed 10 years. I need to get new ones. I'm like, well, what's the problem? So I basically go on symptoms. So if you've got no symptoms, I personally, and surgeons are different. I think some people, I think they would sort of say you've got to change them every 10 years and would change them every 10 years. The problem with doing that, there's potential complications and issues with having surgery, obviously. So I would not advise having surgery unless you had to, sort of thing. So I would say to you that if you haven't got a problem, you don't need to have the implants changed. A lot of the implants, all the implants we use at the clinic are guaranteed for life. So the implant themselves is guaranteed for life. So they're not built to need to be changed. Having said that, you often do need to change them. So I'm not saying they're going to last forever, but you often do need to change them. And the reason that you might need to change them, the most common reason that you would need to change them sort of long term, is capsular contracture, scar tissue forming around the implant, making the implant go hard. So if you have a hard implant, you might want to have it changed. That's, as I said, the most common reason for having an implant changed. If you haven't got a hard implant, then you don't have to have it changed. Rupture is another reason, but I don't personally scan for ruptures. I don't go looking for ruptures. Some people will kind of routinely scan patients for ruptures because, for a couple of reasons. If you're asymptomatic, I'm like, I don't want to cause you problems. And sometimes the scans have said that they're ruptured and they're not, and sometimes the scans say they're not and they are. So that's something to be aware of. So if you're having surgery just because a scan said it's ruptured, you can say, well, it probably is ruptured. The scans are pretty accurate, but there is a small chance that they are not ruptured, and vice versa. The scan might say it isn't ruptured and there's a small chance that it is ruptured. So it can kind of create more angst than it actually cures. So if you're asymptomatic, I personally don't do anything except go on your symptoms. So if you've got no symptoms, then you don't need to have anything done. And oh god, I think it says here, did it say, did it pop? Oh yeah, minor polyurethane, had them 11 years. So polyurethane, one of the best things about polyurethane is that they've got a much lower rate of capsular contracture than silicone implants. Polyurethane implants are even less likely, got a good setup here, very very professional setup here. I think you'll agree. Polyurethane implants have got a really low risk of going hard, 1% at 15 years, 1 in 100 at 15 years. So that's the great thing about polyurethane implants. And so, yeah, if they haven't got any problems, I would say you don't have to have them changed. Obviously, talk to your original surgeon, all that sort of stuff. But in my practice, I don't recommend patients have them changed routinely. I only change them if there is a problem, and the most common problem would be hardening. And polyurethane implants, the beauty of them is they're much less likely to go hard. So if they're not hard, you've got no problems, I offer people follow-ups with me to keep on the books sort of thing. But if you haven't got any problems, you can just see what happens, and you might get a capsular contracture. So it's not 0%. There is a chance you could get a capsular contracture, and if and when that occurs, then you might look at having them changed. But that's my view on changing implants. And I do know that some surgeons say that you've got to have them changed every 10 years, but I'm not sure where they got that from, to be honest. A lot of people in the world seem to say that. People come to clinics, they've got to be changed everything. I'm like, where'd you get that from? Where's that come from? Where's the 10-year change thing? Where's that? Who said that? Did the implant company say that? No one told me that, you know. So yeah, that's my take on it. So yeah, so they're fab. So yeah, stay. That's it then, Sassy. Keep going. Well done. I like polyurethane implants for this reason, that they don't go hard. Well done, you. It's good news. So, can you remove an infected cyst? Can you, or would you? So there's a lot of things you can do, but I wouldn't, basically. So I wouldn't remove an infected cyst personally. So it's quite common for people to have cysts for many years. They get infected, they get red, they get angry, they get painful, they ring us up and say, oh my God, quick, you've got to get me in. It's all painful, it's angry, all this stuff's coming out, it's all horrible. And actually we'll be like, well, no, we're not going to do it now. We want to do it when it's quiet. We want to do it when there's no problems. Because if we do it to get a cyst out, you have to make a cut in the skin and get that cyst wall out. And there's all sorts of reasons you don't do it when it's infected. Number one reason, the surgery is horrible. Local anesthetic never really works very well in an infected area. It's all mushy. It's very hard to tell where the cyst wall is. It's just horrible doing surgery in the presence of infection. And when we close up the skin, there's a very high likelihood that wound is going to get infected if there's kind of infection in the area. So it's not good to do surgery on an infected cyst. So what we'd say is, if you're infected, get the infection sorted out. You might need some antibiotics. Sometimes you might need to have it incised, drain. Again, that tends not to be us. That'd be more like a general surgeon or a different type of surgeon who might kind of help you with the if it forms an abscess, and then they have to let out the evil humors. And that there are things that might need to be done for an infected cyst to get over the infection. Once you got over the infection, then you can look at doing something about it in terms of removing it. So we would want to see you a few months later, once the infection's over, and then when it's all quiet, when it's all died down, and there's just like a cyst there, then we would talk about removing it. So it sounds bad, but we're not very helpful when people ring with an infected cyst. Kind of want to be helpful, but there's not a lot we can do really with infected cysts. It's like we can't do anything about it. You need to sort out the infection, which might need antibiotics, might need sort of lancing or opening up. Might not need anything. It might stay on its own. I don't know, but it's not really. We don't really get involved when there's when there's open or overt infection. There we wait for it to settle down. So and actually, once it's been infected, it's a little bit more difficult to do the surgery later because there's kind of scar tissue around it. So it's a bit more difficult to tell where the cyst wall is, because when you do the surgery, you want to try and get rid of that cyst wall. And if you can't really tell where the edges of the cyst wall are, you're a bit more likely to potentially leave some behind, and it can recur. So ideally, you would remove a cyst which had never had any infection, but that's an ideal world. If you've got an infection, you have to wait for it to settle, and then we can do it. You might be able to get it out nicely, but it's a little bit more difficult. Gyratory. Do you have names like that? Gyratory? I've got a boring name. What's my name? The Staiano Clinic or something. Anyway, Gyratory says, why do cysts smell? So what smells is the stuff inside the cyst. So it's often the case when you're doing the surgery, if you breach the wall, you try not to breach the wall, to be honest. You try and get it out as a kind of as a ball. But if you do breach the cyst wall, this stuff comes out, and it's like this cheesy stuff that's got a smell to it. And it's just sebaceous material that's been accumulating inside the cyst. I don't know specifically why it smells, but you're absolutely right. It does smell, and there is quite a distinct smell to it. And you know, it does happen if the cyst bursts when we're removing it, or if it bursts, if you have a cyst and it bursts and all stuff comes out, you will get that. You will experience that smell. It's a bit unpleasant, but if it is infected and it bursts, it's actually quite satisfying in terms of the pain. Will often get better when it bursts, so that actually might make you feel better if it bursts. But yeah, is there such a thing as scarless lipoma removal? Well, interestingly, I saw a patient the other day. She had quite a big lipoma on her forehead, quite a big one here, kind of like the size of an egg, not the depth of an egg, but the size of it. Yeah, a big one. And she said it was a lot bigger, and she'd had injections, like fat dissolving injections in it, and it went. I thought she was going to say I had fat dissolving injections and it was a nightmare, but she said no, I had fat dissolving injections and it went, but it came back, and they said it might come back. So I don't know what's going on there. So I guess if you have fat dissolving injections, that will remove it scarlessly, but it came back again. So does that not permanently remove it? I mean, I've not, to be honest with you, I've not heard of fat dissolving injections being a treatment for lipoma before. I'm not familiar with it, and I was surprised when she kind of made out as if it was a good thing, that it had done a good thing. And I thought to myself, crikey, what am I going to find when I come in here? Is it all going to be all like, you know, scarred up or something? But because I went on to excise it, but it was all right. So yeah, I would say no, there's not a way to remove a lipoma scarlessly. Sometimes when lipomas are very close to the skin, and especially on the trunk, I find it a bit more difficult when they're on the face, but when they're on the trunk, you can make little stab incisions, and you can kind of squeeze it out, and it pops out, and so you leave a small scar. I mean, it's still a scar, but you can leave quite a small scar, because a lipoma's got a bit of giving it a cyst. You just say try and get the cyst wall out, so you probably have to make a slightly bigger scar for a same size cyst than you would for a lipoma, potentially. Having said that, a cyst is usually right underneath the skin. Lipomas can be deep, so the deeper it is, the bigger the scar. But if there is a lipoma right underneath the skin, then you could potentially do it with a smaller scar, but that's not scarless, is it? It's still scar. So I'm going to say no, there's not a way to remove it scarlessly, although that woman did have a temporary removal of it with that injection, but we don't do the injection, so I don't really know anything about that. But someone said something here. Great cyst chat. You want cyst chat? You know where to come. How long have you been a surgeon? Sassy, was that Sassy? Yeah, Sassy. How long have I been a surgeon? I answer a lot of my questions like depends. It's terrible, isn't it? It's just give an answer. I mean, like when you become a surgeon, there's kind of different levels of becoming a surgeon. So you become an FRCS, which is a fellow of the Royal College of Surgeons, or at least was FRCS when I was there. It's now MRCS, a member of the Royal College of Surgeons. But anyway, so I was a fellow of the Royal College of Surgeons. Crikey, I'm going to get this wrong now, these dates. Like, oh, I've got it all on the wall in the clinic. Probably I was going to say 98. Don't know why I'm going to say 98. Actually, I've got my CV. Oh, I saw my CV. Yeah, CV. There we go. Right, I can answer your question, Sassy. I've got the figures here. Okay, So a fellow of the Royal College of Surgeons, that was, 98, look at that, 1998, I was a fellow of the Royal College of Surgeons. So that's when you become a Mister. You know, there's this thing about people becoming a Mister rather than Doctor, and at the time it's quite a big deal. After a while it becomes less of a big deal, but anyway, people like think, oh, I'm Mister. But anyway, so I became a Mister in 1998. And sometimes you see these places, these clinics and things that say, oh, well, our surgeons are FRCS. And I think, crikey, that's actually FRCS is quite a basic surgical qualification. You kind of have to do appendectomies and things like that. And you do sort of, you know, relatively sort of, you have to rotate through certain surgical jobs. You have to do general surgery. You have to do orthopedics. I think you have to do A&E anyway, and a couple of others. So you have to do certain, it froze, oh God. You have to do certain surgical jobs to become FRCS, and then you get to become a Mister. But the more important thing is, so I've been a Mister, I guess, since 1998, which is ages. And then you have to then go on to do specialist training. So if you want, and this is where you come to choosing a surgeon. Never accept to live from strangers. Yeah, wrote a book on it, how to choose a surgeon. There's stuff in the media about this at the moment. You have to then do specialist training if you want to become a specialist. So someone with FRCS is a very basic qualification. So what you're or MRCS, what you're looking for is them having done specialist training. So following the FRCS, you then have to do 6 years of specialist training. Now, for something like plastics, and that's the plastic surgery, so then that's when you become a plastic surgeon or an ENT surgeon or a general surgeon or a cardiothoracic surgeon or an orthopedic surgeon or whatever, ENT, you know, whatever your specialty is, then you do a period of specialist training. So in plastic surgery, it's 6 years, and it usually takes a year or two to get on one of those specialist training jobs because they're competitive entry, and you often have to do a higher degree. So I had to do a master's degree. Some people do a PhD. I think people are doing that less now. But anyway, so I got my FRCS Plast in 2005. So in 2005, that's when I sort of became a specialist. I got FRCS Plast, and that's how you know someone's a specialist. So they've got Plast or ENT or I think ENT might be ORL. Otorhinolaryngology, but anyway, or orth or general surgery weirdly is a specialty. So I know it sounds like it's general, but it's not general. General surgery is kind of usually bowel, like colon and things like that, hernias and bowel anastomoses and things. So so look for letters after the name of the FRCS to look for someone being a specialist. So what do I specialize in? Well, I specialize in plastic surgery, but then once you become a plastic surgeon, you then subspecialize in plastic surgery. So as I said earlier, you can have hands, head and neck, burns, breast. So breast is my specialty. I was a breast reconstructive surgeon when I was in the NHS, and I did breast reconstruction. So in the private, I did mainly breast, did tummy tucks as well. I'm moving more towards the minor ops now, the lumps and bumps. I'm sort of moving away so much from the breast stuff and the general anesthetic stuff, but I'm still doing a bit. I've sort of gone back to it just recently, trying to build the clinic. I've got other people at the clinic, so I'm trying to build that up and get other people to work with me. So I'm doing midwifery, so I love to know people's background. Yeah, so yeah, that's mine. So FRCS Plast since 2005. I think I got my consultant job 2007, I think. So that's when I became a consultant in the NHS. I was at City Hospital, as I say, doing breast reconstruction. I was there for 5 years till 2013. I left the NHS in 2013 to open my own clinic, which I think I opened in 2014. I think I had a year, and then I've been there since, so 10 years now in my clinic. So that's how I've got. I'm based Edgbaston in Birmingham, near Five Ways Roundabout. I don't know if you know Birmingham, but anyway, Edgbaston, quite central. Yeah, there you go. That's me. Donna is in the house. What have you learnt new, Donna? What was new in that? RCS Plus and stuff? Anyway, there you go, Donna. Nice to see you virtually. Hope everything's all right in Droitwich. Wish I, you know, well, not in Droitwich anymore, am I? Hospitals don't, struggling a bit with the private hospitals, but I used to like Droitwich. But there you go. Can't look back, can we, Donna? Got to look forward. Yeah, looking forward. Yeah, got mine done at Maya. Well done. You got yours done at Maya. Okay, excellent. Well done. Nice one. You got. Hold on a minute. You got yours done at Maya. Polyurethane implants. I don't think Maya used polyurethane implants. Nah. Did you say you got polyurethane? Maya don't use polyurethane. Sound right? Oh well. Maybe they did use polyurethane. I thought Maya used a certain kind of brand and they all used that one. But anyway, I might be wrong. Don't want to be. I have to do a revision. Oh, okay, right, okay. So they might use it for. Yeah, that's fair enough. They might use it for oh yeah, because not many people use polyurethane primarily. It's often reserved for revision cases. Yeah. Okay. So yeah, they're good in revision. I do use them primarily, but yeah, it's quite common for people to use them for revisions. I'll explain it. I wouldn't hold. Right. Okay. Fair enough. What are we doing here? Do we remove thread veins? No, that would be a vascular surgeon. So that's another type of subspecialty of surgery. That would be a vascular surgeon. We did have, well, I say we had. We never. I spoke to Alok Tiwari, who's a vascular surgeon in Birmingham. Did he do some work? Or he was thinking of. Anyway, he's a vascular surgeon in Birmingham. I think he's based at the Priory. Mr. Tiwari. He might well be able to help, but we don't do them. Yeah, that different type of surgery need for that. Do we remove port wine angiomas? Well, again, that we don't do port wine angiomas. Now, again, that is still, so plastic surgeons might do that. That's something that would be done with laser. So this is a capillary hemangioma. So it's a vascular anomaly. It's an abnormal amount of blood vessels in a certain area, and it presents often on the face as this sort of red lesion or red area. And like I said earlier, the red is good because it can be targeted by laser. The red. Oh, Sassy's got to go. Okay. Yeah, thanks for coming, Sassy. Thanks for letting me know you got to go. Excellent. That's nice. Most people just go, but that's good of you to let me know. So the laser can target the red and can and is the mainstay of treatment for capillary hemangiomas. So that would be a laser person you want for that. So that's, yeah, we don't do laser. Never really got interested in laser personally, and I think that's one of the sort of things about the clinic. It has been my personal practice. Basically, it's based around my personal practice rather than being a kind of commercial clinic. If it was a commercial clinic, I don't know, we'd probably have lasers and vascular surgeons and God knows what. We'd probably be doing all sorts. I mean, we don't do Botox, can you believe? Simply because it's not in my transom at the moment. So yeah, we just do what I do, which is what was breast and body contouring, but now I'm transitioning more to moles, cysts, lumps, bumps, see and treat. So you come and have it done in one day. Donna, you made a great point about skin cancers. I think that's a big push for us if you've got a suspected skin cancer, because I think the NHS is struggling to treat these sorts of things. So we are we're trying to give people an appointment within 7 days. It's kind of like a thing, trying to be a bit like Domino's said that they would give you the pizza hot in, I can't remember what it was, half an hour or something. I mean, I don't remember either. I read about it. Was it half an hour? They said, or you get your money back. We're not going to give you your money back. Yeah, but it's kind of like that, putting a sort of a number on the commitment. So we're trying to say, look, we're going to give you an appointment within 7 days. Now, you might not be able to make that appointment, in which case, fine. But we're trying to put ourselves in a position where we can offer you an appointment within 7 days, which I think is helpful with people who've got lesions that they're concerned about, and they just want them gone. Because you send us a photo, we give you a price, we let you know what's going to be done, and then you come, as I say, appointment within 7 days, and that's an appointment to have it treated. So basically, there's no waiting time, there's no waiting list. You don't get put on a waiting list. You just come, have it done, and we'll go, I suppose, after that. That is the that is a plan. Now, official charity shop Sue, what's the best hair transplant, darling? What's the best hair transplant? What, like the best type of hair transplant? I haven't got a clue, Sue. Going back to the clinic being my main thing, it's not really a commercial clinic that offers everything. We don't do hair transplant. I think Ken Cock does it. Does he? He had a clinic called Hair and Follicle in Edgbaston. I don't know if he's still there, but I think Ken Cock was doing it. Who does hair? I mean, Greg Williams does hair transplant in London, and a good friend of mine. So he would. So I don't. It's another world, Sue, and I can't. I better not try and put my oar in, because I'll probably get it wrong, because I've got no experience of it. So I'm not going to be able to give you a balanced view on it. So it's a quite a big thing in itself. Greg Williams, as I say, in London, is quite. He's a plastic surgeon who's kind of specialised in hair transplant, which is quite a niche for plastic surgeons. Some plastic surgeons do it a bit, I think, but not many people go all in on it, and Greg seems to have gone all in. So Greg is kind of really influential in the hair transplant world. So he would be a great opinion, but it's not my Farjo, the Farjo clinic. Heard of the Farjo clinic? Besson for Farjo. I think he works for the anyway. But Greg's good. I'm not sure about Ken Cock. I don't know if he still does it. Hair and Follicle, I think, was his name of his clinic. What's this? Hold on a minute. Is bowel cancer? Wait a minute. Is bowel cancer rare in young 30s? Yeah. Cancer in young 30s is rare. Yes, it is. So if you have got that, then you would probably be looking at sort of genetic predispositions. Well, bowel cancer is not my field. That would be a general surgeon, but that is rare in the 30s. Do you do it in the kitchen? Do what, Sue? Do the cooking? Yes. Do the hair transplants? No. As I said, I don't do hair transplants at all, but I certainly don't do it in the kitchen. The best surgery. Okay. Is bowel cancer rare in 30s? Okay, thank you. Are you single? Right, okay. Not sure if you're on the right. It's mainly plastic surgery questions, Sue. We're trying to focus it onto plastic surgery questions. So that's my forte. Is the plastic surgery questions. So thank you, doctor. You're welcome, Lax. I don't know if I answered one of your questions, but you were. Oh, yes, I did. Is bowel cancer rare in the young 30s? Yes, it is. Thoughts on anxiety and stress. Does stress mess up digestion? I'm sure it does. I do believe, and not very medical this, but I do believe, if you have kind of positive mindset, and if you do, I found this with surgery, people who are very positive. I mean, you've got to tell everybody the bad things that can happen. You don't want to be unrealistic about expectations, but I do believe if you are positive about things, then you're going to get a good outcome. And the flip side is true. If you're worried about things, if you focus on things, you do find those people do tend to get more problems. I do anyway. I mean, so I do find there's an element of your mind, affecting it. So yeah, I'd probably do the same as anxiety and stress. Does it mess up digestion? I wouldn't be at all surprised. I think the mind is a very powerful thing. But that's not very medical. I don't know from a medical point of view if it does. But digestion and kind of bowel cancer and stuff like that is not. I'm a plastic surgeon, so bowel cancer is a bowel surgeon, a gastrointestinal surgeon, a general surgeon would be their sort of their title will be a general surgeon. As I said earlier, general surgeon is quite sounds like they're general, but it's not. General surgery is a specific field where which deals with bowel problems. When I'm stressed, it makes me go to the toilet. But yeah, I think that's common. I think it's a common kind of fight or flight reaction. I think when you're a caveman, I think emptying your bowels when you are ready to fight or flight is probably some kind of part of the survival mechanism. So I think that's normal. I think we're digressing a bit. I'm getting a bit outside of my area of expertise, but happy to have a bash at answering kind of these kind of questions, but I'm not sure how knowledgeable I am on it. Are you single again? Right. Okay. So TikTok is right. I tell you what. Look. Oh my lord! Is that the time? Right. I got to wrap it up. If you've got any questions, call me, message me, email me, do whatever you got to do. And if you're lucky, I can't guarantee it. If you're lucky, you might get on next week's show. Next week is Christmas, isn't it? But I think it's not Christmas, is it? It's the week before. It's all rushing up, isn't it? In fact, it's nowhere near. It's the 10th, isn't it? So that'll be the 17th. So that'll be the week before Christmas. So I think it'll be normal next week. So I'd love to call you, sir. Okay, Lax, well, you can call me 0121 454 3680. You can call my office, and if you've got any questions, please ask them. But actually, about digestion and bowel cancer and stuff, we're probably not the place to look for help. But yeah, good. Okay, so without further ado, I'm going to let you get on with your respective evenings. Thank you for your involvement, Donna, Lax, Roxanne, Charity Shop Sue, and Sassy Amori. I will declare myself out while the going is good, and don't fear, because I'll be back next week with more of the same. And look at that. Who's that? Sorry, Vicky Walker. I'm about to sign myself out of here. It's also going to find the right button. But I say sorry. You're probably all right, aren't you? You've probably got other things to do. Right, just signing myself out. And now. But